I split the talk into two parts. So one is medicine. And I like this, the medicine of veterinary business. Whether you like it or not, we're in business. And if you're like, well, I'm an associate, you're in business with me, because if we're not successful together, we got problems. I think right now, talking to the veterinarians I've spoken to in the last couple days, you guys that are right there with us are the problems that we're going to have in veterinary medicine. Too many vets. We're going to have a surplus. We have it now in the US. Now the veterinary schools are increasing the class size, and we have more schools opening, like you guys have. And do you really think we need more vets? I'm not sure we do. That's going to add a surplus to the market. So I think right now, more importantly than ever, we need to differentiate our practices from our other competitors. I mean, I think right now, you need to be a great veterinarian, but you better be thinking of things like customer service, or you're going to have a hard time. In the US, number one problem we have, internet pharmacies. You're getting a little bit of it, trust me, you don't know what's coming. Because if you saw what was happening to us, we're getting really killed on the pharmacy in the US. Not just the internet, Walmart, Walgreens, large corporations. I can't blame the clients, but it's affecting our income, there's no question about it. So I'm concerned about that. I think the better practices will be okay. If you're just vaccinating dogs and selling products, I think you're in real trouble. I really do. When we're going to do a workup, do a full workup. CBC chemistry, electrolytes, and urinalysis. Nobody wants to get urine, so they don't. You get these blood testing results with no urine. That's a mistake. You really need the urine to interpret the biochemical profile. So CBC chemistry, electrolytes, UA in a dog, that's our minimum database. And in the cat over 7, we're going to throw in a total T4. One big thing that we're really talking a lot about now is the routine monitoring of laboratory data. Serial evaluations, that's what you want to do. What do I mean by that? We want to get blood tests on animals when they're healthy. That way we can detect disease earlier on, later on in their lives. That sounds great. How hard is that to get the clients to do? Hard, right? Hey, I know your dog's 3 years old and it's completely healthy. Would you like to do like a $280 workup? Oh, you don't? Okay. Well, nice try. However, saying that, I think there's some ways that you can improve your compliance on that, especially pre-anesthetic testing that I'll talk about later. But this should be our goal. The best reference range or interval for a pet is their own reference range when they're healthy. That's what you want. The way the reference ranges are developed are not very good. Take 120 dogs and cats of different sizes and ages, and we're going to take the top 2.5% of that lab analytes results and the bottom 2.5%. We're going to throw those out, and that's our normal. That's not very accurate, is what you find. Different breeds, different sizes. So when we get blood work, we're taking a picture, a snapshot of that, what's going on in that animal at one point in time. I want a movie. That's what I want, not just a snapshot. Best example of that would be hematology. Hematology changes hourly. If I do a CBC and send it off to the reference lab and I get it back 12 hours later, to me, that's too long. That was 12 hours ago. You want the movie. Perfect example, there's several analytes that are great to trend and you should start right now trending them. Creatinine is a perfect example. Creatinine, BUN and creatinine, we all run them. Not very good tests. Certainly not sensitive for renal failure. 75% of our nephrons, our kidney cells, are not functional by the time BUN and creatinine increase. That's why we have such poor luck treating renal failure. It's because the car's burning, right? That's when we diagnose them. I want to know when the maintenance light comes on in the car. Because then maybe we have a chance at treating that animal. So what we've learned is if this is the normal reference interval, reference range for a dog or cat, this is an older poodle that we were trending, creatinine is pretty stable. When it starts increasing, even in the normal reference range, we don't want to start intervening right there, maybe doing other tests, like urine protein creatinine ratios, or dietary changes or more frequent monitoring. You want to know what's normal for that dog. Creatinine does not change much in the lifespan of a pet. Hematocrit is another perfect example. It's pretty doggone consistent throughout lifespan, and there's a lot of analytes like that. You want the movie. I don't want just a snapshot, or you're going to miss a lot of things. I want the movie. Here's our first case that doesn't work out, by the way. So this is Shelby. This isn't really Shelby, but I wanted to show you what a normal Maltese looks like. Shelby actually came in completely recumbent. I can't do degrees centigrade, so let's say the temperature was low. Heart rate high, tachycardic, shocky, ecchymotic hemorrhages and petechial hemorrhages, mainly in the inguinal area. Both scleras are hematomas. So I was concerned about this dog. Maybe we got a coagulation disorder. This dog's in really bad shape. So here's our hematology data. So what everybody's doing right now is everybody's going up here and looking at the highs and lows. And nobody's looking down here probably and wanting to read these graphs. And I understand that because no one's ever shown you how to do that. So this is off the Pro site. Wouldn't it be great if I did the IDEX talk and I told everybody, I use the Abaxis analyzers? That'd be so fun. I would love to tell them that. I really like the Pro site. I'm not paid to say that. I'll explain why. One are these graphs. So I realize these are probably foreign to you, like me. And everybody's looking up here. So I'm going to ask you to pause for a moment, and I'm going to show you a new way of interpreting the hemogram, which is the CBC, which will make things much better for you and will prevent some of the mistakes that a lot of people make, okay? And this is out of our guide to hematology, the dog and cat, kind of in the notes that I gave you. So let's back up and let's do a little 10-minute crash course on hematology. So the hemogram is the same thing as the CBC. Red cells, white cells, platelets, total protein. Total protein is part of hematology because it gives you an idea of hydration. So when you're looking at hematocrit or packed cell volume, which by the way are not the same thing, and I'll get to that, you want to look at hydration status. The animal's dehydrated. Usually albumin will be elevated, sodium and chloride will be elevated, and urine-specific gravity will be concentrated. When I look at hematology, I'm looking at the urine-specific gravity, electrolytes, chemistry. That's what I said before. You need all four parts to put them all together. You're solving a puzzle. Here's a picture of the bone marrow. Remember, all these cells are coming from the bone marrow. These are white cell precursors right here. Bone marrow. What you're looking at with the CBC is you're looking at a balance between what's happening in the bone marrow versus the tissues. And we're collecting blood, which is the conduit, the highway to those tissues. With the red blood cells, what are we concerned about? A lot of this you know already. First question I'm asking myself, I like to look at the red cells first, then the white cells, then the platelets. If you divide them into those systems, you'll do a lot better job. So with the red cells, the first thing I want to know, is the animal anemic, polycythemic, or normal? You're already doing this, I know that, but that's what you're doing. I look at hematocrit or packed cell volume, which are not the same thing. Is the animal normal, anemic, or polycythemic? About 10 to 15% of our veterinary patients are anemic. We see it a lot. You know that already. The next question is really key, though. In your anemic patients, is the anemia regenerative or non-regenerative? Which brings us to the first point today that I want you to remember. I have 5 things you probably really need to know today. One is, every animal that's anemic, you must do an absolute reticulocyte count. Why? If you do not, you can't tell whether the anemia is regenerative or non-regenerative. Why is that such a big deal? Because when there are regenerative anemias, I think blood loss or hemolytic, and that's the path that you want to travel diagnostically. This is a big deal. If it's anemic, is it regenerative or non-regenerative? Use the absolute retic count. If it's regenerative, in other words, if the reticulocyte count is elevated, do we think the mechanism is blood loss or hemolytic? Hemolytic anemias are the most regenerative and will have the highest reticulocyte count because you're not losing blood. So if you have a hemolytic anemia, like an immune-mediated hemolytic anemia or a Heinz body hemolytic anemia, you're tearing the red blood cells apart, but you're saving the hemoglobin, you're saving the iron, you're not losing it. Whereas with blood loss, especially chronic blood loss, you're losing blood, you're losing iron, you're going to have less of a regenerative response. The cat is less regenerative than the dog. This is where everybody makes mistakes, and we need to fix this. White cells. So the first statement I'm going to say, which we totally screw up, which is bad. Quit looking at the total white blood cell count and thinking it means much. It doesn't. I almost don't care. Don't think a high white blood cell count means an animal has an infection, because you're going to be wrong almost all the time. That's one problem we do. The animal has a high white count, it has an infection. No, it doesn't. How about parvovirus? What does that have? A low white count. How about a stress leukogram, which is very common in dogs, which is the second question. I want to spend 2 minutes on the stress leukogram. Why? You see it every day. You saw it this morning in a sick animal. If you don't know how to recognize it, you're missing it. And it's a really important syndrome to understand. Stress leukogram is this. First of all, a minimum of 4 hours to occur. This isn't the mean cat, right? The wild cat you're holding down. Not a stress leukogram. Stress leukogram takes minimum of 4 hours. And most of our veterinary patients have been ill for days, so guess what? You're going to see it. Here's the syndrome. You're ill from another disease. Cancer, pancreatitis, IMHA. You pick the disease. Adrenal glands secrete cortisol, and that creates reproducible changes in the leukogram. So here's what it does in order of appearance. Lymphopenia is the most common finding. Low lymphocytes. You're going to find that with a stress leukogram. Low eosinophils. Mature neutrophilia, not a left shift, which has bands, but a high neutrophil count that's made up of mature neutrophils. And that can go up into the 20,000 range. Yeah. So you can get in, when you add them all up with a stress leukogram, you can be looking at 20 to 30,000 total white blood cells. Another reason you can't say an animal with a high white count has an infection, all right? So low lymphs, low eos, mature neutrophilia, monocytes normal to slightly increased. You won't have all those things in every stress leukogram. Sometimes you'll just have a lymphopenia. Very important syndrome. Why is it so important? It's a sick animal test. That's why. How many animals a day do you and I look at and you're like, why are they even here, right? Dr. Fred, receptionist comes back. Dr. Fred, Mrs. Jones just called up. Buffy's on her desk doorstep. Can we fit her in? Of course, bring her in. Bring Buffy in, right? What's Buffy do? Buffy looks better than you do, right? Don't the clients apologize? I'm really sorry. At home she looked bad. Well, you chase them around in a white coat. A lot of times you learn over the years, they do look better at the office than they do at home. So one rule I always use is, the animal's sick if the client thinks it's sick. That's one. If they have a stress leukogram, something is wrong. It's the maintenance light. You know the light on your car that comes on? Maintenance required, right? It doesn't say what's wrong with your car, but a light comes on. That's hematology. That's the stress leukogram. Something is wrong. Can't tell you what it is. Something's not right with this animal. And when I see it, you need to do more tests. Maybe I'm going to do an ultrasound, or obviously I've got the whole profile, but something's wrong with this animal. If you're going to check a dog for Cushing's, they better have a stress leukogram. If you have a real sick animal and the lymphocytes and eosinophils are not low, I think of Addison's disease, right? Sick animals should have stress leukograms, especially in the dog. Is there evidence of tissue necrosis? What does that mean? If you have an abscess or dying cells, a necrotic tumor would be a perfect example. You're going to have a monocytosis. Monocytes eat dead stuff. And systemic hypersensitivity is basically allergies. Eosinophilia is basophilias. We blame too much on parasites, just so you know. I'm for not blaming parasites for everything. The parasites that will cause an eosinophilia or basophilia are migrating parasites. Heartworm, you guys probably aren't going to see a lot of that. Migrating parasites, hookworms, roundworms, not whipworms. Whipworms don't migrate. They're not going to cause an eosinophilia. Certain types of tumors you'll see in eosinophilia. We all know mast cell tumor. Let me tell you a more common one, lymphoma. A lot of them have an eosinophilia too. Platelets, are they high, low, or normal? Clearly we're more concerned about low platelets. This is a dog from a blood film. It's a DIC. Here's a blood film with an enlarged platelet. Maybe it's a King Charles Spaniel. This is what the King Charles Spaniels have. This is really common in the cat. So cat platelets can be small and large, and this is why impedance counters really fail with cats. So not to be too nice to IDEX, but if you have an impedance counter like the Abaxis or Heska analyzer, it's not that they're bad analyzers, but you take a platelet that should be this size, maybe 2 microns, that it'll do a good job with, and now you throw one of these enlarged platelets in a cat, it's going to count it wrong. It's going to count it as a red blood cell. That's a problem. Here's a banned neutrophil, by the way. Acanthocyte. So when we look at the CBC, this is basically what the tests mean. So red blood cell mass, the big one is hematocrit. Notice I said twice now. Why do I keep saying hematocrit and packed cell volume aren't the same thing? There's got to be a reason there. There is. Packed cell volume is where you take a microhematocrit tube and spin it in a centrifuge and you pack the red cells down. That's packed cell volume. So you're going to get that 2 ways. One is by spinning it down yourself, or if you have the QBC vet auto reader, right? QBC, a lot of things I don't like about that, and I'll point those out. One thing I like, it does a packed cell volume. It spins it down, it does a centrifuge. Everyone else, ProCyte, LaserCyte, Reference Lab, Abaxis, Heska, calculate the hematocrit. Hematocrit is a calculation. And because it's a calculation, you can have things go wrong during that calculation. Depends on the analyzer. Most of them look at mean cell volume and then do a calculation. One rule that I'll show you in a little bit, I like to take hemoglobin, multiply it times 3, and that should approximate the hematocrit. So if hemoglobin is 10 times 3 is 30, I'd expect an hematocrit around 30. If hemoglobin's 15, I expect a hematocrit around 45. Let's say it's calculated and it says 42, I'll take that. But what happens if it says it's 28 with a hemoglobin of 15, something's screwed up. Maybe you have hemolysis. Then I'll do a packed cell volume. Hematocrit, packed cell volume are not the same thing. We both use them to determine anemia, but they're different things. Use the absolute reticulocyte. This is your best test for bone marrow regeneration, the absolute reticulocyte count. Get that with every anemic patient. You'll hear me say at the end, and I'll show you a case, where you actually want it with every case, whether they're anemic or not. This is a huge test in veterinary medicine. This is why veterinarians are buying LaserCyte and ProCyte, because of that. The white blood cells, the total white blood cell count, I look at it last. I barely care. I'll look at it. I want to know the differential. I call it the 6-part differential. I've invented the 6-part differential, just so you know. Neutrophils, lymphs, monos, eos, basos, and bands. That's the 6-part differential. That's what you want. Platelet mass. What do I think of percents? Don't use them. If you use percents, you'll make horrific mistakes on hematology. Don't say an animal has 10% eosinophils. It doesn't mean anything. You want the absolute count, this. Red blood cell morphology. I actually use these, and you probably should too. What's RDW? We get it on all these reports. Here's everybody. The RDW's on.
Red cell distribution.
Yes, excellent. You're like the only person that even knew what that was. Do you know what it is, though?
It's a distribution of the red blood cells.
Various sizes. It's a measure of anisocytosis. So what that means is, if all the red blood cells are the same size, it's going to be normal. If it's high, that means you have various size differences, small and large. You know what this really means to me? If this is high, low I could care less about. If this is high, it's saying, I know you don't like doing blood films. You have to, all right? You guys are better. Almost every other country is better at looking at blood films than the US. They're not that hard to do, and sometimes you have to. I don't care if you have the ProCyte. I don't care if you have the reference lab. You got to look at the blood sometimes. I mean, come on. You have to. If this is high, I look at it. You know where I use MCV and MCHC? I call that my secondary hematology profile. I'm more worried that people know how you tell whether an anemia is regenerative or not in the white cells. The second part of that is there's some cool things you can do with MCV and MCHC. One thing you can't do, as I'll show you in a minute, is use it for regeneration. You have to use the retic count for that. But iron deficiency anemia, low mean cell volume, low MCHC. So microcytic. MCV is the average volume of a red blood cell. If it's low, we call that microcytic. If it's high, we call it macrocytic. And if it's normal, guess what we call it? Normocytic. Unbelievable crowd here gathered in Sydney today. MCHC is mean cell hemoglobin concentration. If your hemoglobin's low, it's low. We call that hypochromasia. You can't physiologically have too much hemoglobin. Sometimes you'll see it high, though, if you have a hemolyzed sample. Okay? We should be getting all of our blood samples from the jugular vein. Certain countries, I say that, and they want to throw me out. Israel's like, we could never do that. No one ever showed you, right? Jugular vein is where you want to get blood samples. Weird things on mean cell volume. Like if I think I might have a dog with a portosystemic shunt, because see, I'm going to do hematology on my prean. God, if you don't do hematology in your prean, you're going to make some horrific mistakes. One thing I look for dogs with shunts, low mean cell volume. Most dogs and cats that have portosystemic shunts have low mean cell volumes. And there's some other weird stuff. Most cats with feline leukemia have high mean cell volume. So it's just another, those are called red blood cell indices. These are called red blood cell indices. My big thing is I want vets to know hemoglobin times 3 should be around the hematocrit. If the hematocrit's low, you're anemic. How do you tell whether it's regenerative or not? You look at the retic count. And then the 6-part differential. We're going to put this into play. So here's what I said. Anemia, regenerative is hemolytic or blood loss. Now, saying that, it takes 4 days to see reticulocytes. So if a dog gets brought into the animal referral hospital here, right now, just got hit by a car out here, has a hemoabdomen, first of all, the hematocrit or packed cell volume is not going to change right away because you're losing plasma and red blood cells together. It's going to take 8-12 hours after you start rehydrating them. Then they're going to get anemic. One thing I will look for is total protein. That will usually be low with blood loss pretty quickly after they were hit by a car. But the point I'm trying to make is, by the time you see reticulocytes, you're looking at about 4 days. So just because it's non-regenerative now doesn't mean it won't be means it won't be regenerative in a couple days. Hematology is a snapshot of the blood right now. Make the movie. If you don't make the movie, you're going to get burned. This is a study that was done, actually a good study. Most veterinary studies are 12 beagles, and then we change everything we've been doing for 30 years because the 12 beagles did this, whatever it was, right? Dr. D. Nicola, who's a clinical pathologist, really did this study. 190,000 CBCs. So anemia is pretty common, you know. 17,000 of these samples were anemic, a little over about 12%. Of the anemias that were regenerative, based on the reticulocyte count, what percent had the pattern high mean cell volume, low mean cell hemoglobin concentration? Because what I was taught in veterinary school, a regenerative anemia is a lot of reticulocytes, which it is. Reticulocytes are larger than normal and have less hemoglobin. High mean cell volume, less mean cell hemoglobin concentration. The problem is those are means, okay? So the study found is the dogs that had regenerative anemias, that had high mean cell volume, low MCHC, 8.3%. It's a horrible test for regeneration. Don't use it. Because an IMHA, spherocytes small, retics big, mean normal. Don't use MCV, MCHC to tell whether it's regenerative or not. Use the absolute retic count. That's why I said that a few minutes ago. Now let's go back to our dog. Now I get all these tests, everybody's looking up there, but we still have not tackled this, which we need to. We need to learn to read the dot plot. Why? It will save you much grief. So when you look at the analyzers that are out there, they all have little graphs and dot plots. No one ever looks at them, but they have them. So the QBC, myself and one vet in Kansas City are probably the only ones that ever looked at this. QBC has this little graph and nobody looked. What everybody would say is, I get these pound signs on the QBC and I don't trust it. Well, These two technologies have been around a long time. There's only so much these two can do with the technology, all right? Not that this is a bad analyzer, it just requires a lot more steps to get an accurate CBC. And you have to be able to do blood films, know how to read the little graph and all that. I don't know about you, but although I like this, I like graphs and that kind of stuff. For modern veterinary practice, I think there's some better alternatives. It depends on what you want to spend. So this is a QBC vet auto reader. Impedance counter, so that's a Baxis and Heska. They're going to look at cell size. These are good on normal dogs. Normally I'm running CBCs because they're not normal dogs, but in the cat, these are problematic because the platelets, like I showed earlier, get miscounted. That's basically what happens. The other thing is these don't do a 5-part differential, these two. They do these modified. Each company has come up with their own marketing scheme, which I think is poor. They don't do a 5-part differential. That really limits you on what you can do with hematology. The QBC puts the lymphocytes and monocytes together so you can't tell whether you have a stress leukogram. The impedance counters put the granulocytes together, right? And this gives you no reticulocyte information. This does a retic percent. LaserCyte and ProCyte. LaserCyte uses a laser flow cytometer and it draws these little graphs. ProCyte actually uses all three. It uses fluorescence, impedance, and laser flow, which I think makes a better analyzer. I'll explain in a little bit. And I'm not paid to say that. That's fairly common knowledge, I think. So my point is each makes graphs. You need to know how to read the graph. So I am now going to show you the ProCyte graph. And right now you don't care, but you will. And you'll be able to use this. So the way these analyzers work, this is ProCyte. LaserCyte works the same way. They draw up your purple top tube, your blood sample, and they analyze the red blood cells and the platelets first. So this is a red blood cell platelet dot plot. Red blood cells are red, platelets are blue, reticulocytes are like this magenta color, all right? Fluorescence is here, which is basically RNA. If you have a lot of RNA, reticulocytes have a lot of RNA. They're further to the right. Platelets are here, red blood cells are here. This is the size of the cell. Platelets are smaller than red blood cells. Here's all you have to know to read these graphs. Everybody thinks they can't read them. The number of dots correlates to the number of cells. So each one of these blue dots that you're seeing is actually a platelet that the analyzer has counted, and then most of them are this size, okay? So if this is a normal number of platelets, normal number of dots, what's a thrombocytopenia look like? Less blue dots. The number of dots and the number of cells, that's the whole thing. Now, if this is a normal dog, go over to this dog. What's the big difference with this dot plot? Do you see all the dots here, which are the reticulocytes? There's more dots. There's a lot of dots. So this would be a reticulocytosis. Number of dots are the number of cells. I know right now you're numb. I get that. Right now you don't really care. You will in a minute. Let's look at our dog. Don't look at the numbers. What do you guys see down here? Look at the reticulocytes in this dog. Oh my God. Anybody else have any other comments? Yes. Low platelets, thrombocytopenia. Here's a normal. That's a normal dog. See how it has less blue dots? It's a thrombocytopenia. And look at the reticulocyte response. Holy, really high retic count. I look at that. Now I go and look at the numbers, not the other way around. Look here. This is going to be like the blood film. I still want to do a blood film, don't get me wrong. But this is going to tell me. The analyzer doesn't make numbers and then draw a bunch of dots because you think it's good. They're going to be able to sell you the analyzer. What the analyzer does is exactly what's in the reference lab. It does the analysis on these dots, and then it puts it through an algorithm and comes up with numbers. So here's what I like to do. Hemoglobin times 3, 2.7 times 3 is 8.1. That's close to 10. 8.1 or 10, I don't really care. That's really anemic in the dog. Okay? So we're anemic. My numbers look different than yours. Like I looked at some glucoses the other day to practice. Oh my God, a glucose of 9? Give it dextrose, you know? It's like diabetic. You know, it's like, or values are a little bit different. But if the hematocrit's low and it's really low, you're anemic. The next question, is it regenerative or not? To be honest with you, I know it's regenerative. But here we have 278,000 reticulocytes. Normal in the procyte is up to 110. That's a severely regenerative anemia. And you know what? I hate to jump too quick, but I'll bet you it's hemolytic. Like, that's really regenerative. If I had to bet right now, I'd say hemolytic. Then we're going to look at the white cells. Oh, one thing I wanted to say, which you won't like, sorry. You know the counters we all have? Neutrophil, neutrophil, eosinophil, monocyte, their nurses do ding, 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 ding. Absolute waste of time. Hate to tell you that. Really? I mean, why is it a waste of time? Because we're not counting enough cells. It's not that our techs don't know what they're doing, our nurses. This came from the American College of Veterinary Pathologists. They did a 500 cell differential with trained ClinPath technicians, which is even more worrisome. 500 cell differential. Not acceptable precision with a 500 cell differential on monocytes, eosinophils, lymphocytes, and basophils. And the bands were even worse. Like, what's a band and what isn't? This is worrisome. And what does that say? What you want to do is let the analyzer that you have, assuming it can do a 5-part differential, let it do the differential. Procyte, laser cyte are going to count 80% of the white cells. So if you have a white count of 10,000, they count 8,000. Let that do a differential, not 100 cells. Because here's the other thing we do with our differentials. We do a 100 cell. No one does a 500 cell differential. And here's the other thing you do. Skip a site, right? I don't know what that one is. You do that on a 100 cell, you got big problems. That doesn't mean we're going to replace the technicians, nurses. No, I want them to look at the blood. Look at things the analyzer can't see. So we talk about a 1 to 3 minute scan of the blood. That's our blood film. We're not doing a differential. Let the machine do that. We're going to do a scan of the blood, and look at morphology and other things, and I'll talk about that in a minute. If you look at the stress leukogram, this is what I said before. Low lymphs, low eosinophils, mature neutrophilia. Notice no bands. Okay? Really important. You want there's the 6-part differential. Notice that was stress leukogram, right? We just mentioned. Now let's look at inflammation. With inflammation, the difference is an increase in band neutrophils or left shift. Bands are metamyelocytes, immature neutrophils. When they're elevated, we have inflammation. Can you see how the inflammatory leukogram looks very similar to the stress leukogram? In other words, low lymphs, low eosinophils, high mature neutrophils, but the difference is the bands, the left shift. Why is that? Because most animals with inflammation have inflammation with stress. This is the most common leukogram change that you're going to see on your sick animals. They have inflammation, they have a left shift, they have bands, and stress. Very common. How often, many times a month do you see that? How about how many times a day do you see it? If you're like, I don't think I really see that, well, you don't have an analyzer that can see it, because trust me, you're seeing it. Or you didn't work. You know, that would make sense too. This is really, really common. We need to be able to pick it up. The band is really important. You can look at inflammation, like what do I be my minimal and mild? This would be something like a cystitis. You're probably not going to have any bands. Clear out to overwhelming, where we have a high number of bands and a low white count. Clearly with chemo patients, you're going to be worried about that. I mean, that's a serious finding. Septicemia, overwhelming inflammation, very important to pick up on, because you can be dead pretty quick with that. I just did the red blood cell platelet dot plots, and we were all yelling out reticulocytes, and that's exactly what I would hope you would do. Now I want to look at the white blood cell dot plots. So we've drawn up, we've aspirated our sample, we did the red cells and the platelets, now we're discarding it, and we're going to go to the white blood cells. Granularity is on the right on the white cells, fluorescence here, so RNA is here. To make a long story short, this is a dog one on the left, cat one on the right. Neutrophils are this color, so here's the neutrophils. Lymphocytes are blue. Monocytes red. Eosinophils green. It's the same deal. The more neutrophils, you'd have more gray dots. So if you had a pyometra, you'd have this giant cloud of all these dots. If you had a neutropenia, chemo patient, you'd only have a few gray dots right here. Dr. Cotto at Ohio State did a lot of studies with the ProCyte, especially on neutropenic patients. It's really good for neutropenia. What would a stress leukogram look like? Less blue dots. More gray, less blue. The number of dots to the number of cells. That's what I'm trying to say. Each species is slightly different. The equine's a little bit different. If you work on rabbits, they have it on the rabbit, ferret. Eosinophils in the cat have more granularity and higher fluorescence, so they're further on the right than in the dog. Number of dots to the number of cells. Now let's look at our patient. So back to our dog, our Maltese. So everybody wants to look up here. If you look at these numbers, you'll screw this case completely up. All right. Do you really think a sick dog that should have a stress leukogram has 18,000 lymphocytes? It shouldn't. The only way it's going to have that is have a leukemia, lymphocytic leukemia. So the next thing I'm about to say is really big, especially if you have the ProCyte. So neutrophils, lymphocytes, monocytes. You can see there's no eosinophils, which makes me already think you had a stress leukogram. These are neutrophils. There's more than normal. Let me show you what normal looks like. So here's normally, it's a nice cloud, an oval cloud that's separated nicely from the lymphocytes, and it sits right here. So I think there's more of them, so I think there's more neutrophils than a normal dog. The other thing that's really important, though, is the pattern. Can everybody see that normally it's oval, and here we have what I've termed a shark fin. It's like a triangle. See it right here? I call it the shark fin. When you see a shark fin, you know what that means? That means you have a left shift. Those are immature neutrophils. Why is that so big? That's your 6-part differential. The ProCyte now has a flag. When I ran this, the algorithm wasn't done yet, but I knew it had a left shift because I could see the shark fin. Now the ProCyte will tell you bands detected in about 85% of animals with inflammation. It's really good. You want to make it better? Look for the shark fin because I can pick it up on almost 100% of the dogs and cats that have inflammation by seeing that little fin. So I want you to remember shark fin. What happens with the neutrophil? And we see this with immature neutrophils and or toxic neutrophils. Toxic neutrophils are neutrophils that are maturing too rapidly. The bone marrow is releasing them before they're ready because you have such severe inflammatory leukogram. This left shift will cause the neutrophils to enter into the lymphocytes and even into the monocytes. And it has trouble knowing where the lymphocytes and monocytes are. Do you see how it gives these asterisks? So it's telling you, hey, don't trust this. We're having some interference. No vets look at that. Where it's like it's got 18,000 lymphocytes, it's inaccurate. If you know how to read the graph, no, it's not. And this is exactly what's happening at the reference lab. At the Sydney reference lab, I just visited the Brisbane lab, which is exactly like the Chicago lab. They have the Sysmex XTV. They have the parent of the ProCyte. It's the same analyzer. They're made by the same company. ProCyte is the baby of that one. The one in the lab runs multiple samples. ProCyte runs one at a time. I think the ProCyte's better. In fact, I know it's better, which might surprise you. How could it be better than the one in the lab? You're running fresh blood samples on it. They're running bloods that are 8 or 12 hours old. So the fresher the sample, the better chance you're going to pick up the left shift. So this animal has a hell of a left shift. Here's the blood film. Gosh, why don't the blood films look like, and you go to these talks, and they always show great blood film, you know? In the books, it never looks that way. I'll tell you why. This is from my scope. One is you have to have a good scope, you know? Veterinary scopes that we have in our practices are not adequate. Here's what it has. 410, 40, and 100x. That's what we all had in vet school, and you took your vet school microscope, and it's in your lab, and maybe even got another one. What you want to do is get a 20x and a 50x oil. Why? They're much better to look at blood with. So the picture that I'm showing you right here on our dog Shelby is a 20x. 4x is too far away. 10x is okay. And then you go right to 40. It's too close, all right? The other thing with blood films, When you stain them, the stain isn't good forever, just so everybody knows. The blue sludge in the third jar, you might want to change that now and then or strain it. You know, it's like this blue lava. People are like, why can't you even get through it? You know, it's like gum. You want to change that, all right? The other thing that people don't do right, the first jar, the light one, the one that you open up and it's strong alcohol, that's the fixative. Drop your slide in there and leave it in there for a couple minutes. Don't dip in that one. Drop the slide in hematology and cytology. Leave it for a couple minutes. Then come out in the orange and then the blue. Here's the other thing we do. We make a big problem in vet med on hematology. Cytology, man, we like that last one. 5, 10, 15. Now we got 2 blue for hematology. Do 5 in the blue for hematology. Look at it. If it's too light, you can go back and restain it. The problem is when you do it really dark, you can never see polychromasia. So this is 20x. What am I seeing? And we're scanning around. This is the monolayer of the blood film. Here's a nice band. That's a seg, and this one's kind of an in-betweener, but here's your left shift. The one thing I like about this power, can you see where you have more normal red blood cells that have areas of central pallor? And then you have some larger ones. And then look at all these. I mean, these are spherocytes. There's spherocytes everywhere. There's platelets. 20x on the left, 50x oil on the right. Lots of spherocytes. Lots of spherocytes. I don't know about you. I don't want to say immune-mediated hemolytic anemia, but I'm about ready to. Saline slide agglutination test. A better way of doing it than, one other thing on blood films. You want better blood films? Do fresh blood films before you put it in EDTA. So if you know you're going to do a blood film, I would draw the blood from the animal, fresh blood on a slide, have someone smear it, then right into the purple top tube. You'll get rid of crenation, because that's a disaster, right? I'd like to see acanthocytes, but it's all crenated. That's what the reference lab's looking at, unfortunately. You want to make fresh blood. Take a drop, instead of doing this and adding the saline, which is what we all do, because we put that on there and it looks gritty, and then we're like, how much saline do we add? I don't know. Looks grainy. Been there and done that. Better way of doing this, purple top, 1 drop of blood, put a cover slip on top of it, and then add the saline around the edge of the slide. 0.9% sodium chloride, you have liters of it sitting in your hospital. Just draw a CC out and put a couple drops of saline around the edge of the slide, then look under low power. And what you'll do is you'll watch the saline mix under the slide with the patient's blood, because sometimes it takes a higher concentration of saline to break up rouleau. Because what you're trying to do is determine rouleau versus agglutination. That's a much better way of doing it. So on the left, this is rouleau, or a stack of coins. It looks like horse blood, right? You add the saline, these are going to disperse. And this is our patient, actually, where we added the saline. We have this 3-dimensional clumping of blood. It's immune-mediated hemolytic anemia and thrombocytopenia, actually. Evans syndrome. This was Schnucker's, who was a really nice cat. You see how icteric he is already? He's really jaundiced. Referred for weight loss. You know, kind of an ain't doing right kitty. Thickened bowel loops on palpation. So here's our kitty. Kind of the same deal, but we're going to split it all up. See if you put it into red cells, white cells, platelets, you can do a lot better job. So I'll let you have a look at that and make any comments you might want to make. I see everybody looking at the dot plots. At least I'm pretending you are. I mean, the big thing on the dot plots is the number of dots. So like that looks pretty normal and that looks pretty normal. You see on the cats how they can have really enlarged platelets normally? This is going to give fits to an impedance counter. That's very common in the cat. So I'm going to call this normal with one caveat. I don't like the hematocrit being low normal. This is where I would love to have previous data, but I didn't. It was a referral. And it's the old where we were at the other vets, they give you the lab work. No, they said everything was normal. It drives me nuts. I'd love to know what that cat's normal hematocrit is. Clearly we're going to do a combo on this cat, which is negative. I love my other vets when they do a giant workup and they're like, what do you think of this? And I just love it. Because I know they didn't do a combo. Did you do a combo? And they're like, no. Then they run a combo, which is negative. But then I take a little blue Sharpie and I make a dot. It's so much fun. They're like, oh my God. Oh, maybe it's just me. Yeah, I make vet practice fun, come on. All right, what do you want to say? Comments? No time to be shy. Shark fin. Right there's a shark fin. Here's normal. Shark fin is this triangle that goes up here. What do you think about lymphocyte numbers? Less blue dots than a normal cat. So I'm going inflammation with stress is exactly what I'm going to go with. Then I'm going to go up here and I'm going to go lymphs are low, eosinophils are low, neutrophils are high. That's a stress leukogram. But I'm seeing the shark fin, that's inflammation with stress. Now, the new ProCyte algorithm is going to tell you bands are detected most likely. Pretty darn good, about 85%. But I don't care whether it gave me a flag or not. I can see the bands right there. So we're going to be in the inflammatory category. Didn't say a lot about the chemistry. I wanted to make this more hematology focused, but I do have some comments on chemistry. This is where our levels look different, you know? So for me, you know, glucose goes up to 159 in a cat. I assume if a cat has a normal glucose, it has an insulinoma, right? Every stressed cat is going to have a high glucose. BUN and creatinine, what do I think about them? Be very careful with BUN and creatinine. They can be normal, and you could be headed to kidney failure. So they are normal right now. I'd love to know what normal is in this cat. So I'm going to say right now, I think the kidneys are okay. Urine-specific gravity is 1045. We're probably okay. But just remember, these are not the most sensitive tests for kidney disease. Protein panel's okay. Then the liver, right? Some pretty big changes. I think these will be the same units for all of us. But dog and cat are completely different. One thing is when you have an elevated bilirubin, you saw how icteric the cat was, you're going to get clinical jaundice at about 3 milligrams per deciliter and above. Serum and plasma will start to get yellow at about 2. When you see this, be very wary of wet systems, wet chemistry. Why? Because when you get interfering substances, it's going to be a problem. And I'll try to do my demo. We'll see how this will work in the camera. So this is serum or plasma. I spun it down. I got a very clear sample. I don't know how the camera will work on this. So here's a laser. I don't know how strong this thing is. Not very strong. We did get new batteries, so that's good. So here's the way the analyzers work. They're going to shine a light through a sample and look for interference. So this is a serum sample, and I'm shining my light through. See the light in the back wall? Pretty good sample. I can shine it through. I'm going to get good results. Now, you put interfering substances in here. So Purdue, where I went to veterinary school, did a study. 73% of veterinary samples have interfering substances. That's hemolyzed, icteric, or lipemic samples. Some patients can have all three, like a pancreatitis dog, you'll have all three. So here's my analogy. An icteric animal, that's orange juice. The laser is not going to go through very well. What's my hemolyzed sample? Tomato juice. And what's my lipemic? Milk. When you have a wet system, you're going to have problems with those samples. Not to pick on the vet scan, but I will. One thing the vet scan did, which is cool, is at the bottom of their printout, they tell you whether it's lipemic, icteric, or hemolyzed. But veterinarians think that it corrects for that. It doesn't. It's telling you that it's a problem sample. What does the reference lab do? They do ultracentrifugation to get rid of it. What's the vet test and the catalyst do? They use dry slides to filter it out. You've got to get rid of that crap or you're going to get some bad results. So I'm going to be really worried about this in a wet system. Liver enzymes, what's the deal? If I could give you just a little brief rundown on liver enzymes. ALT is an hepatocellular leakage enzyme. Alphos and GGT are biliary. Well, you already knew that, and who cares? Here's the analogy I use. Big cluster of green grapes. I like green grapes, so I'm holding the stem up. It's a giant group of green grapes. So all the green grapes are here, and I'm holding the big stem. So my fist is the gallbladder. This big stem is the common bile duct. Then you got smaller bile ducts coming off that. Smaller, smaller, smaller. And then finally, they go right into a grape. The grapes are the hepatocytes. That's ALT and AST. The stems, GGT is mainly in the gallbladder and the large common bile duct and the larger bile ducts that come off the common bile duct. Alkaline phosphatase is in the smaller bile ducts that are further out in the liver. There are both biliary duct enzymes. They're different locations. Does that make sense? You want to have both of them together. If you're not getting GGT and alk phos together, you're missing a lot of liver disease, especially in the cat. Because GGT in the cat is my favorite liver enzyme. Maybe my favorite liver enzyme in the dog too. Why? In the cat, alkaline phosphatase has a half-life of 6 hours. It goes up and down in the cat and it's gone. GGT is about 3 days. You need to run these together. You got to get GGT in the cat and the dog profile. Because on the vet test profile and the general health profile, GGT is not in there. And what I used to do is I would take amylase out of that and buy a box of GGT and put it in there together. You got to have GGT in the dog and the cat. The vet scan doesn't have it. Doesn't have it on their general rotor. I think that's a mistake. You can buy it on their mammalian rotor, and then you're running 2. You got to get GGT. So in the catalyst, that's why you have the Chem 17, which is the dog clip. That was us. Chem 17 is the dog clip. It has lipase and GGT. The Chem 15 is the cat clip. No amylase or lipase because you don't need that in the cat, but it has GGT. And then the Chem 10 is the pre-an. The problem with the YPAP, or the young pre-anesthetic panel, on the vet test is it didn't have albumin. I mean, that's stupid. So guess what we did? We put albumin in the Chem 10. That's what you want. So ALT is an hepatocellular leakage enzyme, pretty high, 428. That's the grapes. Alkaline phosphatase in the dog will be commonly elevated for non-specific causes because the dog has a corticosteroid-like induced isoenzyme. So alk phos in the dog are commonly 3. Usually we get worried when it's 3 to 4 times the high end of normal. So in the dog, on the catalyst, let me give you an example. This is a cat. But in the dog, alk phos goes to 212. So if it's above 600, 700, then it has my attention. Less than that, it's pretty common in the dog because once again, the dog has the corticosteroid-induced isoenzyme. If they're stressed, they have a stress leukogram, expect the liver enzymes to be slightly elevated. The cat does not have a corticosteroid-induced isoenzyme, so anytime alk phos is elevated in the cat, that's important. So if normal's 111, if a cat had 112, that worries me. That's too high. Okay? GGT, 24 times the high end of normal in this cat. That would be high. That's worrisome. So I'm thinking liver and bile ducts, small bile ducts and big bile ducts in this cat. On the urine, we had a 2+ bilirubin. You shouldn't have bilirubin in the urine of a cat either. In the dog, you'll see a tracer 1+, but bilirubin in the urine of a cat should be negative. This cat had a 2+. We did an ultrasound, an abdominal ultrasound. These are bowel loops. And the bowel loops are a little thicker than normal. This doesn't show up particularly well, but this is the liver. We did a fine needle aspirate of the liver, which normally I don't do. I'd rather do laparoscopic, but we got an icteric sick cat, so I don't want to anesthetize this cat, so we did do fine needle aspirates. Fine needle aspirates are okay if you get lymphoma, not for the cat, but if you get lymphoma, you got your diagnosis, right? If you don't, normally you get hepatic lipidosis, which is what we got on this cat. This cat had some ascites in the abdomen. This is a big lymph node we stuck. Reactive lymphoid hyperplasia, not lymphoma. We did a we did a SNAP FPL, feline pancreatic lipase, which was abnormal. The SNAP FPL, which is the cat one, and the SNAP CPL, great tests, but we don't use them right, all right? If you have a normal, that's very helpful. That means pancreatitis goes to the bottom of the list. Very unlikely. If you have an abnormal, pancreatitis is in play, but it does not mean the dog or cat has pancreatitis, and I'll explain. Because a lot of people think it does, and it doesn't. I want to show you the dog SNAP right now. So SNAP CPL. The SNAP CPL, so if you send it to the reference lab and get a spec CPL, which is a number, in the dog it's going to say greater than 400 consistent with pancreatitis, 2 to 400 in the gray zone, less than 200, that would be a negative or normal. This would rule out pancreatitis. The SNAP CPL and FPL are In the dog, 200 or less. In the cat, it's a different range. It's like 3.5. So let's look at the dog real quick. If a dog has 200 or less, it's negative on the SNAP. That's great. Makes it a very handy test. The problem is anything above 200, it will be abnormal. So what happens if you have a dog with 280? That doesn't mean it has pancreatitis, but it's going to show up abnormal on the SNAP. So here, cut to the chase. What do you need to know? A normal SNAP, CPL and FPL, effectively rules out pancreatitis. It's not 100%. Nothing's 100%, but it's pretty darn good. Those are normal. Pancreatitis way down. If it's abnormal, send it to the lab and get a spec FPL or spec CPL and get a number. Find out where you're at. And remember, animals can have concurrent diseases. I had a dog a couple years ago that had a foreign body in pancreatitis that I almost killed because I'm treating as a spec CPL over 1,000. If it's pancreatitis fluids, the dog's not getting better. I'm like, we better look in there because I was going to do a feeding tube. I thought maybe it had an pancreatic abscess. It had a pair of socks that were right over the common bile duct. I mean, so, right? Still got to be a vet too. This cat had triaditis. So it had pancreatitis, inflammatory bowel, and IBD. One thing I'm showing here, does everybody see the really big shark fin? So on the pro site now, this is what it's going to say. It's going to see banned neutrophils detected or suspected. It says it twice, so it's just so you see it. There and there. I see it right there. That's revolutionized veterinary hematology, is to have a banned flag. It also does nucleated red blood cells. That's only on the pro site, not on the laser site. I like laser site, but not as much as pro site for that reason. Let's look at one that lived. Let's look at a happy one. This is one that's really cool, and this is something that you probably, hopefully don't know yet. So we're going to send you out of here with something. This is a dog that presented for hematuria. I love this dog. It's a great dog. Her name's Kayla Dudas. Comes in for hematuria. I won't bore you with the details. I'm looking at the dog. Ultrasound the bladder to do my cysto. Dog's got bladder stones. Right? That makes sense. So we talk about, doing the surgery. We talk about SD and antibiotics. She's like, how well does that work? I'm like, if that were me, let's just get him out. We'll analyze him. We'll fix the problem. She needs a dental. Great. So on the pre-anesthetic profile, which I'll let you look at, here's her pre-anesthetic profile that we did. And I'm going to make it bigger so we can go red cells, white cells, platelets, just like we've been doing, and then we can actually look at the dot plot. So here's the red cells. Platelets. That's kind of interesting. And it's saying we have 144,000 reticulocytes. Here's the previous data that we had on her. So I looked at this and went, which you might be like, what does that mean? And I'll tell you. There's normal, but like this isn't, there's definitely retics there. So we have a high reticulocyte count in a dog that's not anemic. Should we care? Yes, or I wouldn't be showing this, right? So we know because of LaserCyte and ProCyte, because it does a retic count whether you want it or not. The reference labs would have only done a retic count in an anemic patient. That's changed. Now IDEX is doing a retic count on everybody because of about what I'm ready to tell you. So I saw that, which is odd. This dog had a splenic mass. So let me tell you why I thought it had bladder stones, and it did. This ended up being a benign splenic hematoma. So here's the list. This is a work in progress. This is what we've learned over the last 5 years, and this will change. But right now, animals that have high retic counts, they're not anemic. What does it mean? There's two groups. Physiologic, there's nothing wrong with them. It's normal for them, and we know that's one group. We can have excitable dogs. We can have dogs on steroids, dogs with Cushing's disease. Just exercise or certain drugs can make splenic contraction occur and the reticulocytes increase. We did a study on dogs that had a high retic count, and we anesthetized them and we brought the reticulocytes down. The more important group that you might want to think about is this over here. So anything that could cause a high retic count in an anemic animal can also cause it in a dog that's not anemic. Why? The bone marrow is compensating for a disease. And if you were to ask me right now, and this might change, but right now, if I were to say what's the most common on the pathologic side, I would say immune-mediated hemolytic anemia. If you look at a lot of those dogs, before they crash and burn, they'll come in, they'll have a normal hematocrit and a high retic count, and it'll keep going up and up and up. And what's happening is the body's destroying the red blood cells, but the bone marrow's sending out new ones. And they're sending out enough that the animal's not anemic yet. And eventually they're going to go. I had a dog a couple months ago that had a retic count of 300,000, had a normal hematocrit. I had one that we watched that was okay, it was clinically completely normal. Retic count from like 200 to 700,000. One weekend, then the hematocrit went. So we think it's an early indicator for certain diseases. The other big group that I would throw in there, bleeding. I've seen it, probably the most common one secondary to IMHA I've seen are bleeding abdominal masses. Look at the splenic tumors that we see. I see that a lot. I know you do too. So the dog bleeds into the abdomen, bone marrow cranks out retics, dog auto-transfuses, dog's not anemic yet. That's a really common one too. So what am I saying with that? Don't go crazy with that. Here's what I said. Some of them are normal for that dog. Some of them are physiologic. So if the dog's completely normal, what would I do? I'd love to ultrasound their spleen. But if the dog's completely normal, I would say to the owners, hey, this one red blood cell is a little bit higher than normal. Let's recheck it in a couple weeks or a month. And if it's going up, or if they'll let you ultrasound the spleen, definitely I would look at the blood too. Make sure you don't see a lot of spherocytes. So this has been very interesting. I had a dog with tetralogy of Fallot, heart problem. I had a dog with a kidney tumor. So we're just learning about this. Dr. Dean Nicola, who's a clinical pathologist in the US, he was my teacher at Purdue. We've done some things together on this, so there's going to be more coming out on this, but that's kind of new info. I think that's pretty cool. So I am saying, that's what I said earlier, I would do a retic count on every animal, whether they're anemic or not.